Hey, welcome everybody to another episode of Interpreting for Healthcare, our monthly podcast sponsored by the National Council on Interpreting in Healthcare. This podcast is intended for you, our members, as well as the public at large, and everyone and anyone working to promote language access and social justice. So please join us for our conversations with some of the best in the field and hear what they have to say about interpreting for healthcare. Today's guest is Jeni Rodrigues, and I want to tell you a little bit about Jeni. Dr. Rodrigues has been a nationally certified sign language interpreter for 25 years, specializing in healthcare and mental health care interpreting. I want to talk more about that because I wish there was a specialized certification for that. She earned her master's degree in interpreting pedagogy from Northeastern University in 2011 and completed her PhD in interpreting from Gallaudet University in 2022. Her work explores access barriers deaf patients face in healthcare settings and best practices in healthcare interpreting education for ASL and English interpreters. Dr. Rodrigues is currently an assistant professor and the director of healthcare interpreting programs at the prestigious Rochester Institute of Technology, National Technical Institute for the Deaf, in the Department of ASL and Interpreting Education. So there's so much in that bio already that I want to know more about. Welcome, Jeni. Welcome to our podcast. And let's dive right in. Let's go back a little bit. And if you look back, because you have such an interesting background, I'd love to see more interpreters with advanced degrees. What are you most proud of when you look back?
First, thank you for that very warm welcome. I'm so glad to be here. I love the work that NCIHC does. And I actually, in the ASL interpreting field, we don't typically, we don't connect with the spoken language interpreting field enough. And one thing that I try to do is bring some of the resources that you've created that are so great into my classroom. So I teach them the NCIHC Code of Ethics and the standards. And so I make sure that my students are familiar with that as well. Probably the thing I'm most proud of is my dissertation. I mean, I think you have to love your work to be able to dedicate that many years to studying it, kind of that, in that infinitesimal detail. So I actually, tell us about that dissertation. So I did a study it's actually called The Letter or the Spirit of the Law, an institutional ethnography of effective communication in US hospitals. So basically, I was stuck with trying to understand how, if federal laws and Joint Commission standards and hospital policy all require hospitals to provide effective communication, access to interpreters, why deaf patients were still not receiving interpreters, and why there are all of these lawsuits. Seems like a no-brainer. So I ended up interviewing interpreter coordinators that were in managing interpreter services departments in several different hospitals to just find out what they're doing. I thought that would be a great entry into the hospital. Since they're the ones that manage services, they might know why there are issues and to start investigating what was happening. There have been lots of studies that focus on providers or patients and their perspectives, but there wasn't really anything that looked at the institutional level for our field in ASL English interpreting. So I was trying to figure out where these breakdowns occur. And as I was interviewing the coordinators, they all said very similar things, which I kind of felt that would be the issue, but I really thought that the problem might lie with interpreter services, something about the way that it was created, or that didn't have enough buy-in, or it ended up becoming far more complicated than I thought it would be. So it was fascinating. So some of the barriers that I found were some of the things that we talk about all the time that I hear on the webinars that you guys do, that in other research studies that have been done on spoken language interpreting. One, of course, the lack of government funding. The insufficient training for healthcare workers in working with deaf patients and interpreters. Providers not understanding their legal obligations. Duh. But then there are things that are specific to deaf patients. There are these ableist views of disability, where the focus is on the medical model of disability. And so this idea that deaf people are always there because there's something wrong with their hearing, as opposed to just needing care. And there's this tendency to infantilize. When speaking with doctors, healthcare providers, it was very clear that they viewed disability differently than able-bodied individuals. They also have these assumptions that all deaf patients can communicate through lip reading and note writing. And there was this constant issue that that came up where nurses and doctors would say things like, well, I understand them, so we're fine. We don't need interpreters. So I actually started with the interpreter services coordinators, and then I decided to do field study, and I went into 2 hospital systems and interviewed. I did observations and interviewed doctors, nurses, clerks, interpreters, deaf patients, and
The people in the
kind of,
trenches.
yeah, exactly. And I asked them questions about, like, what do you do in your everyday work? How do you, what are all the things that you do to make sure that deaf patients get access? And it was in seeing how this person's work connects to this person's and this other person's, where I could see that potential gaps could occur, and did. Like, if the clerk accidentally forgot to schedule the surgery on a specific date, the deaf patient would have no interpreter. If a clerk forgot to select preferred language in the language of care field, no interpreter shows up. They don't show up in interpreting services lists.
I see some similarities though with spoken language. Obviously, there's going to be some differences, but there's also going to be some commonalities. Even in a hospital that has interpreting staff and that has gone to the trouble of correctly identifying by training those initial points of contact, all initial points of contact, to know what that patient's preferred language is. And they are having an interpreter accompany them to an appointment in person, or they have access to an interpreter virtually. That doesn't mean that all the stops within the system provide language access, whether they go to the pharmacy or get fitted for an appliance or have to go to financial services or wayfinding or many places where that falls through. And from my own experience of being a child of immigrants who were well educated, but whose English made them sound less educated, that perception of the teachers always talking down to my parents as if they couldn't comprehend the most basic things. I see those two sort of in a parallel universe between deaf and hard of hearing patients and those that are limited in languages that other than English are preferred as their first languages, or are in fact their first language. but I would like to know more about where you spotted some differences, or where you spotted some unexpected holes that people could fall through. For spoken language, even at a hospital with interpreter staff, the big hole in the system is when the patient has to call to change something, right? That phone tree is in English. Even to get to interpreter services, you have to understand English enough to follow the directions correctly to be able to speak to somebody in Spanish, even the most highly demanded language. And that's for people who can hear. So what happens for that rounding back with your deaf and hard of hearing patients?
The one thing that kept presenting over and over in each of the hospitals, when we spoke with deaf patients and when I spoke with interpreters, was when they're in the hospital and they ask for an interpreter. So they've already been seen and they've had an interpreter, but now it's later and they need to speak to the nurse. And the nurse decides that it's short enough that they don't need to call an interpreter because the deaf person can lip read and they can write back and forth. And so they don't need an interpreter. And this happens over and over again. There was one patient that I followed in the emergency department, and she called for an interpreter literally, it was 10 times while she was there, as she moved from one person to the next. So she had to go to radiology to have scans done. And then she had someone come in and do blood work. And then she had transport come to move her to another location. So it was constant, individual after individual. And at those hospitals, they don't have an interpreter who's just seated at bedside because they have staff interpreters and multiple deaf patients. And so the interpreter will go and make sure that all needs are met, and then they leave and they inform everyone to page them if they're needed again, but they're not paged, even if the deaf patient asks. And this kept happening over and over again. It was this idea that, and it was this misunderstanding about how to work with deaf patients. The other thing that I found was the over-reliance on video remote interpreting. When I first did the study, it was pre-COVID. So post-COVID, it's a completely different situation. And I actually circled back to the hospitals to find out how they navigated through the pandemic. And because some of them were very resistant to VRI. And as they moved through COVID, of course, they had to transition and they had to make friends with technology. But most of the issue is that I think when interpreting with deaf patients, they're just like in spoken language, there are regional differences. And deaf individuals become very familiar with their interpreters. And so, right, and so the interpreters know all the deaf people. And so to have to talk to someone when they're already not well in another state, who doesn't know them, who doesn't know their medical history, is very jarring. And so that is one issue. And then the other is that there are several issues with not having high enough internet speed. The infrastructure wasn't built well to be able to support. And so the picture is pixelated, which is not that big of a deal for spoken language interpreting, but for us, it is imperative, right? And so many lawsuits are as a result of VRI not functioning the way it was intended to. There isn't enough training. Even when it works well, the nurses don't know how to turn it on. They don't know how to charge it. So that was a big
learning. You have an on-site interpreter who could be paged easily to return, right? We have to maximize resources so they can't sit there all day waiting for
exactly
next opportunity to interpret. but they need to be called back. And yes, we have video to fill in while you're waiting for that interpreter to be called back, so that that person doesn't go having to ask 10 times to be able
Right.
to communicate their thought. But I also see some similarities again, because we were, let me out ourselves to the audience, we both speak Portuguese as our other language, and we were talking about the differences in accents in Portuguese from different parts of the world. And where do patients go when they don't get an interpreter that fits their needs? It may be a bad interpreter in terms of skills, but what if it's a good interpreter who speaks with an accent from the Azores, and the patient is somebody who's from southern Brazil, so those Portugueses are really far apart? How does the remote interpreter communicate that that was not a good match? There really isn't something built into these platforms for the interpreter to give feedback when it's a less than satisfactory experience. And patients often don't know they have the right to complain. And where is the faith that that complaint will do any good if they've asked for an interpreter 10 times and not gotten one? So again, there's differences. And for example, not having the visual for the deaf and hard of hearing is a deal breaker.
Yeah.
Not as much of a deal breaker for the spoken language encounter. It does help body language. You can tell if that person is understanding,
Right.
because
Of
you
course.
have a face that is accompanying the conversation, rather than, when the eyebrows come together, there's a problem. But you can still communicate. Without the visual, you can't use sign. So that is a larger, bigger and outcome impacting hurdle for deaf and hard of hearing patients than spoken language limited English proficient patients have to face. But then again, there's also those similarities. What do you do when it's not a good match? Why is the system not addressing that? Why can't feedback go back up the chain? You're pushing out a lot of product. Why can't we give comment? I mean, some language service providers allow the provider to click 1, 2, 3 stars as to how satisfied they are with that interpreting encounter at the end of the encounter. It's a start, but that is just too vague. Where does the operator, where does the interpreter get a chance to ask for something that would improve, or to contribute data that they could track to figure out what needs to be improved? So, yeah. So we need more research like the kind you've done in order to show in an empirical way, which is the way that you get administrators and IT people on board, that this would streamline processes, improve patient outcomes, improve patient satisfaction, and all of that, and speak that C-suite lingo. And
Yes.
there's not enough of that data out there. So I'm really, really happy that you have that. And please, whatever you're willing to share with National Council, we do have a library of reliable resources that people who work in interpreting services departments or in language access can consult to help make their case, to help pitch for their grant for not getting their budget slashed, by pointing to cost savings, reduce length of stay, reduce percentage of readmission, like all of those things that we know are true if you have a reliable, consistently used language access plan for whatever your facility is. So if there's anything more you want to tell us about that study, go ahead, or I'm going to go on to the currently, what do you see as your biggest challenge question?
I had a thought and then it just left. Sorry.
That's okay.
No, it was related to
about your study. So how
I
many
remember.
interview? Okay.
No, but I can answer that about how many people I interviewed.
What's that,
Uh,
Jeni?
so I started with the coordinators. There were six initial coordinators. And then when I went into the field study, I observed a total of 90 individuals comprised of all the people I mentioned, the healthcare providers, nurses, nurse managers, clerks, deaf patients, companions, both hearing and deaf. So that was a whole other issue, which I know that you experience in spoken language interpreting as well, where there's this over-reliance on ad hoc companions to interpret and all the problems that causes. So I interviewed an additional 30 individuals from those initial observations. Generated so much data. Only a part of it went into the dissertation, so I'll be writing articles for a while. The thing that I was going to say that I now remember, aside from converting the dissertation into an article, I'm also creating something for interpreter services managers, directors, so that they have a kind of a step-by-step list of best practices that were suggested by the people I interviewed and that came from the dissertation, precisely so they can use that.
Yeah, it's frustrating, and I try not to let my Latin side get activated and angry and move that energy into teaching. That so many years after Title VI was passed, there's still people who are like, what is a language access plan? I have no idea how, it's supposed to be under their purview. It's like, okay, step by step, you need to have all of this in place before you can say, where's the interpreter, or get this document translated. And it's a long list of things that you need to think about and research, and then delegate that task and responsibility. What's the top language spoken in your zip code? If you don't know the answer to that, there's some research that needs to be done before you can really access a language access plan. You've got to build it. And then, just like Field of Dreams, if you build it, they will come. People will drive incredibly long distances for a healthcare appointment if they know that they will have access to an interpreter for their language.
Absolutely. That's one of the things I found. Yeah, and people kept talking about the other hospital. That's an entirely different article I'm probably going to write based on that as well, where everybody goes to the hospital that they go to because the hospital near their home did not provide them interpreters or gave them subpar experience. And so they drive 2 hours out of the way just to go to this hospital with the good interpreters. It's just very problematic. So
yeah, you can definitely expand your client base if you have the services in place for people to understand what's happening to them. And I know I still need to work on my tone when I explain things, so that it doesn't sound like this is so obvious. Why are you still pretending to be ignorant of this fact? But the work is out there. There's still plenty of people, and then there's new people coming up all the time. But I have to say, the younger they are, the easier it is to make the argument. There's like so much less resistance from residents that I trained in the 90s versus now. It's like night and day. So that gives me hope. But unfortunately, they're not in charge of hospital budgets and clinic budgets yet. So we still have some work to do to try to move more people over to our side. So what do you see as the biggest challenge right now to get more people on board with no longer resisting the need to create a plan to address Title VI and Americans with Disabilities Act and Section 57?
Oh, that's the $1 million question, right? So I think that the idea that there's one thing that we can fix that will then like solve all the problems is we need to throw that out clearly. Right? There are all of these different points where gaps exist. So addressing each of them is necessary. And then kind of the idea is as we address each of them, we make incremental changes. And then hopefully things will keep getting better. But increasing training, like you said, with residents. I know at Strong Hospital, where I also work as an interpreter through University of Rochester Medical Center, they have this Deaf Strong program where they teach incoming med students how to interact with deaf patients, where they actually become the patients having to interact in an all signing hospital, and they're the only hearing person, and trying to figure out how to communicate with all of the staff. It's mind-blowing for them, and it really helps them understand what that must feel like for a deaf patient. So that's effective. Having
More places,
yeah,
University of Washington also would have staff interpreters who were willing to participate, get paid for their time, but bring in a family member or a parent as a patient and just let the resident practice interacting with a patient with an interpreter present during that encounter. You need to have a hands-on experience in order to not be so hesitant to do it when the need arises. Even when we introduced video remote interpreting, I made sure that I went to those staff meetings, even for the night shift that occurred at 3 or 4 o'clock in the morning, to pass the device around and make sure everybody had a chance to press the green button and initiate that call, and then press the red button to hang up, because we made it as idiot proof as possible, but you still needed to give people the opportunity to touch it and do it, or it will just be a great dust collector in the closet. People are afraid of something like, ooh, what's that? That's new. Oh no,
totally.
I saw that in the staff meeting and I touched it and I placed a call and I know how to use it. So yeah, more hands-on, more practicum with the experience of working with an interpreter. Or I love your example of being bereft of the ability to communicate in a way that works. Like that must stick with those residents for the rest of their lives, even though it lasts however long, a day, a half day, a couple of hours. It still must be the very first time for many of these really bright young whippersnappers to feel so helpless, right? And that must stick with them for a while, I would imagine. What kind of feedback have you gotten from participants?
Well, I haven't participated directly in it, but I've read the research studies and I know some of the people who have been involved in it. And that is exactly the response, is just this empathy that they develop. And it actually doesn't only help their, like I said, it doesn't only impact their interactions with deaf patients, but really with all patients. And it makes them softer. It reminds them that they could be a patient too in that situation. And yeah, it's amazing. I also spoke to a few healthcare providers who had gone to just general training on deaf culture and how to work with interpreters. And some of them indicated that was the first time they'd ever met a deaf professional. And that it was kind of a wake-up call for them that they've only see deaf individuals as patients without professions. And so there's this disembodied kind of standardized patient where they categorize all deaf people. And so they realized something about deafness that some of the stereotypes and barriers that they had were dismantled. I'm not
Yeah,
articulating
coming
that
face
well,
to
but
face with unconscious bias is the best
yes,
way to be
yes,
able to
exactly.
encourage it, right? If you don't even know that's how you thought, and now you do because something has contrasted sharply enough for you to go, oh, the reason I thought that was because of this preconceived belief. I
Exactly.
let that go. So that's good for everybody's growth. So well done, all of the organizations that are doing this. And please, all other organizations that are taking time to listen to this podcast, try something like this out. The first week your residents come to your hospital, let that be their sort of initiation week and throw a couple of these experiences at them. Only benefit everyone who comes in contact with that provider going forward, I would think. See what we can do to make that happen. So looking forward, you say you have a lot more articles coming out because there's so much data to dive into. So what are your projects going forward? And then in a broader, more general sense, what would you like to see come out of this? What would you like to see happen?
The first are converting the dissertation into an article and submitting it to a journal to get published, hopefully. And then creating the document for interpreter services, department coordinators, managers. And then I'm looking at a project to kind of develop a best practices for a healthcare interpreting education, using the resources that you've created in the spoken language interpreting field for interpreter training, and then taking our resources from ASL English interpreting and kind of pulling the education programs to see what they're teaching and kind of bringing that all together to create something. So that's very nebulous plan that I've just started working on. And on that line, one of the major issues that we have in ASL English interpreting is that we don't have certification for healthcare interpreters. We don't have standards. We can use yours, but a lot of hospitals don't require certification unless the state requires certification or licensure. And so the onus is on the hospital to screen, and most hospitals don't screen, or they rely on the agencies to do the screening, but most agencies don't screen. And so we don't know if the interpreter is qualified to interpret in healthcare settings. Our certification exam only tests minimum qualifications for general settings, not for healthcare. And it's getting better. In the last 10 years, we have a number of programs that have been developed. So that's great. And thankfully, CCHI just came out with the English to English certification. So I'm hoping that ASL English interpreters can take that and then have something that indicates that they're able to do this work.
ASL interpreters can currently take the written, which will be considered part 1 of this new certification. And now the E to E portion will be part 2, so that there is both a written and a skills proficiency assessment. Even though it's not directly the spoken language, it still is the skills necessary to interpret well: attentive listening, accurate recall, extraction of meaning. And if you've attended the webinars, you see that there are a number of things that can be tested without going specifically into Portuguese or Tagalog or Somali or any of the languages that people are looking for, Urdu or or Dari. And this, I hope, will help move things along, because we need a unity of
Mhm.
assessment certification to go along with our unity of purpose. And I think the data that you have mined will help with one of the latest efforts of my work group committee and standards training committee at NCIHC. This year we'll be looking at what should the standards be for programs that are longer than the small 40-hour Bridging the Gap, which was the trailblazer.
Mhm.
But leading up to an actual bachelor's, there's a lot of stuff in between that nobody's really looking at. What is the content? What should be included, say, in a 120-hour program? What should be included in a 1-year certificate program? What should be included in an AA degree? Not the exact syllabus, but there should be so many hours of skills. There should be so many hours of standards and ethics. There should be so many hours of X, Y, and Z to give guidance to all of these people that are coming up with training, whether it's online or at community colleges or larger colleges and universities, so that we deliver a consistent interpreter product. At least I think that would be a valuable thing to try to pull together and make available to everybody for free. Hey, if you're doing a course and it's this many hours, make sure you have this, and that. And you can put it in the way that you like to teach and in the order that you wish to present, but don't leave any of these pieces out. I think would be a good thing for everybody.
I'm so glad you said that. One of the things that is unique about our university is that we do have healthcare mental health courses in the undergraduate degree, elective courses that students can take just to get kind of an introductory taste of those fields. We then have the 9-month certificate program. It's 160 hours. And then we were accredited by CCHI last year, which was very exciting. And then we have a master's degree, which is the only one that exists specifically for healthcare interpreting. So it's been fascinating to see what additional we put into the certificate as opposed to the undergrad classes, and then how we expand that into the master's program. So that's another project that we need to do, is actually document what we're doing and what works and what doesn't.
That's awesome. And I have a feeling we'll be talking in the future.
I think so.
Why reinvent the wheel in two places? I will be happy to share what we find with you so that we can put something more complete together. And believe it or not, even though it feels like it's only been 5 or 10 minutes, we probably have gone over our time. And I want to thank you so much for being here today, for meeting you virtually, for knowing that this will be an ongoing connection, I feel. And thank you for sharing the information and some of what you learned in your dissertation work, which I know took a big chunk out of your life. We look forward to seeing the additional articles and publications that come. And as I said, we welcome them into our library online if we can help with the dissemination of that knowledge. So thanks everyone for joining us today. And thank you to our guest, Jeni, for being here with us today. It was a great discussion. Tchauzinho. We'll see you next time.
Ciao. Thank you, Eliana.
Bye-bye.